Hello everyone, this week we're going to be looking over skull patterns as part of our clinical imaging course this week. With the skull, there's 11 different ways that the skull can show us that something is wrong. Again, this course is not for us to be able to diagnose, but it is for us to become familiar with looking at some of the patterns that we're seeing on our patients' images. Here are the 11 patterns that we're going to look at this week. We have basilar patterns, button patterns, cystic lesions of the mandible, demineralization pattern, celoturcica changes, increased calvarial density, intracranial calcifications, paranasal sinus masses, multiple Wormian bones, osteolytic skull defects, and also radiodense mandible lesions. Again, we're not trying to memorize any of these, but we are looking for the patterns. We're kind of trying to look for where the patterns are occurring in the skull, and we're also going to briefly look at the kinds of changes that we'll see and also what causes those changes. As with all other chapters, we started out with an analogy, and this analogy for this particular chapter is think of reading a skull film like a home inspection. So if you've ever purchased a home, or even if you lived in an apartment or were renting an apartment, you always do some type of home inspection. So the first thing you look at is the foundation and the frame, typically then the walls, determine if there are any holes in the walls, and then also you inspect each individual room. So with the foundation and the frame, or where the house actually sits, where the base sits, and also where the sutures close, if they close on time or not, this is the conditions or the patterns that we'll see with basilar and also Wormian bones. All right, the second category is the walls. How much bone is actually there? If we have too little bone, meaning there's demineralization there, or if we have a very dense calvarium or mandible. Either way, it's going to change the whole structure itself. So that's what we're looking at for the walls. All right, the third thing is holes in the walls. Sometimes we have either a patch or some type of puncture going on, or there's something that's punched out clean through. The holes are going to tell us a different story about that skull. So again, that is another category that we will look at. And the last category is what's in the actual room. So in the skull, we have the pituitary fossa, we also have sinuses, and we also have brain tissue as well. So some of these things can swell, they can calcify, or they can fill in with masses. So this is the area where we're actually looking at what's in the actual room. So all of the patterns that we're going to look at basically will tell us about the skull and what's actually happening in the skull, and it'll answer some questions for us as well. Now we're moving on to our sorting categories that we have for those 11 patterns. All right, and just like every other week, we've had, for this week, we have 4 sorting categories. So there's something going on with the shape or the suture patterns. There's something going on with the density. There's a density change in the bone. There may be lesions in the bone, or also there may be sella, brain, or sinus findings in the bone itself or in the skull itself. So in terms of the shape and structure, we're looking at the foundation of the skull changing in some way. All right, so it might be that the base migrated upward, and when we say the base migrated upward, we're talking about C1 and C2. So typically there's something that softened in the skull around that base area where the foramen magnum is, where the spine actually enters the skull, and the base of it, or the odontoid process or the odontoid tip, is usually poking up a little higher than it should be. The other category that is there are that the patient's sutures didn't close up or harden or ossify on the time that they should have. So with that one, we're having either those basilar changes or also those Wormian bones. The Wormian bones are when the bone or the sutures don't ossify on time. The second category is the category where we talked about the walls filling. So we're talking about some sort of density change. There's either too little bone or too much bone that we talked about earlier, and this is going to be throughout the calvarium or the mandible. We might see things like demineralization or, again, increased density of that calvarium and also radiodense mandible lesions. All right, the next thing that could happen is a hole could somewhat open up. So we're talking about a hole in the wall. And this can be like a discrete lucent type of defect, or it can be a single defect or multiple defects. So we're talking about the button changes or the lesions of the mandible or some of those osteolytic defects of the skull. And the last category is where we see that there is some sort of content change, whether it's an abnormal size, whether there's calcification or some sort of mass, and it could be in the pituitary fossa, it could be in the brain itself, or it can be in the sinuses. There's also can be some celoturcica changes or some sort of intracranial calcifications as well as sinus masses. Now we're going to look at some of the measurements and also some of the mnemonics that they use to look at some of these skull findings. The first one is the McGregor line. So that's a measurement from the posterior hard palate to the inferior skull margin. They look at that measurement on a lateral film. With basilar invagination, it is possible that when the odontoid, again, we said earlier that due to that skull softening where the odontoid enters the foramen magnum or the base of the skull, that it is a little bit higher than it should be. On men, it's typically going to be about 8 millimeters higher, and on women is going to be about 10 millimeters higher. With the celoturcica, in terms of measurements, it's normal up to 16 millimeters anterior to posterior, 12 millimeters in depth, and also there's typically a double floor sign as well with 2 cortical lines. That means that there's some sort of mass that's eroding the floor of the skull unevenly. Next, we have that donut lesion versus the sequestration. With that, the donut is like a lucency that they find. Usually it's an incidental finding. With the button sequestrian, there is some calcification, central calcification. It's still worth a closer look in terms of what are the symptoms for that patient. There's also 3 mnemonics that are used to look at these skull classifications. The first one is COOP, and that is for our basilar invagination. So there are congenital anomalies. There's also that OI, osteogenesis imperfecta, that you learned about earlier in the term. We have the osteomalacia and also the Paget's disease. So the COOP is just the different diseases so that you don't have to say the names, but all of those are grouped in the COOP. Then we have an Help Me mnemonic, and that's for our osteolytic skull defects. So that's the hemangioma, the epidermoid or dermoid cyst. Then we have the leptomeningeal cyst and also Paget's disease. There's also some post-surgical changes that can happen with this one. We can have metastasis going on, or we can have eosinophilic granulomas or eosinophils as well. And then the last mnemonic there is pork chops, and that's for the wormian bones. All right, so here's some big words for you. We have psychodystosis. We have osteogenesis imperfecta. We can have rickets in the healing phase. We can have kinky hair syndrome. We can have cleidocranial dysphagia, hypothyroidism. We can also have hypophosphatasia, autopallidigital syndrome, acroosteolysis, or pachyderma parostosis, or also Down syndrome. So really big words. I think the first one I might have pronounced incorrect. I think it's pycnodysostosisis. Pignodysostosis. So again, really big words, but they use those acronyms because they are really big words. But again, these are some measurements that they look at, and also mnemonics to classify some of the disorders or conditions that can be happening with that patient. Now we're going to look at some of the case files that will kind of show us some of the skull patterns that we might be interested in or that we might see on a patient's image. The first skull pattern is basilar invagination. Again, it's an upward migration of the skull base. So we're talking about the C1, C2 area. The odontoid is actually sitting higher than it should be. On a man or a woman, there's a specific measurement. So with this, again, that means that the skull base has flattened out and the odontoid is actually sticking up higher. This is typically going to be diagnosed on just a regular bone image, skull image. The patient could potentially have additional imaging with CT or MRI. MRI would probably be the best one to show if there's any neurologic effects due to this disorder or this pattern. Again, this is where they use the McGregor line. So there's a measurement that they use on a skull, lateral skull image, and they're measuring from the posterior hard palate to the inferior skull margin. Again, the odontoid tip is usually more than 8 to 10 millimeters above. On men, it's 8 millimeters. On women, it would be 10 millimeters. So some of the causes, if you can remember the last slide, this is the mnemonic COOP for the causes. Most often it's from some sort of bone softening disorder, whether it's OI, osteogenesis imperfecta, osteomalacia. We could have Paget's disease or maybe rickets as well, and all of those can deform that skull base. Even though it could happen less often, it happens due to congenital anomalies like atlanto-occipital fusions, assimilations, and also foramen magnum stenosis. Again, this is your basilar invagination. Another thing that you might see on this type of patient is they might have a defect in the calvarium. Sometimes there might be defects seen in their clavicles and their pelvis, or it can happen as a result of trauma, and also it can happen as a result of a skull fracture. The next case file explains your button sequestration. It's basically the patient has a lesion, usually a single osteolytic lesion somewhere in a central focus of calcification. With this, there is a sclerotic rim. Typically, we call it the donut lesion. There could be some aggressive pathology used or needed to rule this out. There are different variations of the lesion. For instance, the pearl is a lesion that's painless. Typically, it's an incidental finding for the patient. There could be pain or disability points also. With this one, most often it's going to be an eosinophilic granuloma. It could be a result of some sort of staph infection. It could be a result of something like syphilis and also TB, usually from the scalp. It could be a result of bone metastasis from the lung, from the breast, from the prostate, or from other primary areas. Less commonly, it is due to necrosis, irradiation, burns, or some sort of electric shock. It is often a very delayed type of finding or presentation. Post-surgical changes usually could happen or change from a burr hole or a shunt, and then often, not often, less common, it could be the result of a primary neoplasm or some sort of cancerous cell. The next finding is related to cystic mandible lesions, and it can be split into two groups. And when we're looking at the pathology of it, it can be seen anywhere in the skeleton, but the causes of it is usually tied to the patient's teeth. So with these cyst-like lesions, they can happen or occur in the jaw, and again, they're going to be related to the patient's teeth. So the main thing to pay attention to is, or the main thing that the radiologist or doctor pays attention to is where that lesion is actually located. With our follicular cysts, they typically form around the crown of the patient's tooth, and that tooth, it's a tooth that hasn't erupted yet. With the periodontal cysts and also the periapial granulomas, they are usually associated with some sort of infection that the patient is having, and is typically near the root of their tooth. So some of the less common lesions are going to be the ameloblastomas, which typically can grow very large. And then we also have giant cell granulomas, which can actually expand and thin out the patient's jawbone. With the solitary bone cysts, they're typically going to be found in our younger patients, and they can typically occur after trauma. So again, when we're looking at cysts, we're typically going to see somewhat of a dark area surrounding the crown of the patient's tooth. When we're talking about specifically the crown of an uninterrupted tooth, we're talking about the follicular cyst though. This is our second category of cystic lesions of the mandible. The first category, we said that the cyst was being caused by something going on with the patient's teeth. With these, it has nothing to do with the patient's teeth. So it's jaw lesions, but again, not caused by the patient's teeth. Instead, they're coming from other diseases that are affecting the bones of the body. So when these are seen on x-rays, we might see areas where the bone has actually been destroyed or where the jaw is actually enlarged. A sign that they look for here is floating teeth. And floating teeth, basically, it looks or appears like the tooth is floating, but what actually happened is the bone around the tooth is lost, and it makes it look like the tooth is actually floating. And this is typically associated with histiocytosis X, but there are some other conditions like multiple myeloma, Paget's disease, infection, and also metastatic cancer that can show this floating tooth. Here's our next category of skull patterns. With this one, we're talking about diffuse demineralization. So it basically means that the bones of the skull are starting to become less dense due to a loss in some of the minerals. On an x-ray, they appear more radiolucent or darker. The most common cause of this diffuse demineralization is osteoporosis. Usually osteoporosis is associated with aging, but there are some other diseases that can cause similar changes, such as these. Some conditions can give us additional clues for the skull finding. Certain types of anemias can produce what we call a hair-on-end appearance. We talked about this a little bit earlier in the term, that hyperparathyroidism can also make a salt and pepper appearance. And then if we're talking about multiple myeloma, it can cause a punched out appearance or area in the skull. All right, now we're moving on to Sella-Turcica signs or changes, Sella-Turcica patterns. Again, the Sella-Turcica is the area of the spine that holds our pituitary gland. Normally, the Sella-Turcica is typically smooth, and it's a very well-defined area or appearance on our X-ray images. If it becomes enlarged or starts to look damaged, what they'll start looking for is what we call a double floor sign. With that double floor sign, we'll start to see two lines instead of one line along the bottom of the Sella-Turcica. What that indicates to the radiologist or whomever is reading the film is that there might be some sort of mass, such as a pituitary tumor, and that mass is usually causing some sort of uneven erosion in that area. Now, there's some other conditions that can cause the sella turcica that to enlarge. One being maybe the patient has increased pressure on their skull, but again, the main thing here with the sella turcica is there will be some sort of change in the size, some sort of change in the shape, and then also they're looking at the floor of the sella turcica. The next skull pattern we're looking at is increased radial density of the calvarium. So basically, if we're looking at an x-ray, it means that those skull bones are appearing wider, brighter, or thicker than they normally would appear. And this happens when the patient has extra bone developing, or even the normal layers of the skull can become thicker or thicken. There are several conditions that can cause this, some that you have seen over the last few weeks are dysplasia, Paget's disease, and also acromegaly, but there's a few others. One pattern that they look at for this condition is a cotton wool appearance, and that one is typically seen when that patient might have advanced Paget's disease, where the skull has these irregular patches or increased density. So again, we're looking for unusually thick or white densities in the patient's x-ray image. The next skull pattern is intracranial calcifications. This is when we see small areas of calcium that show up on the inside of the patient's skull on their x-ray image or even on their CT. An important thing to know about calcifications is they are somewhat normal, especially as the patients are getting older. The radiologist or the doctor will become probably a lot more concerned when those calcifications show up in locations that they consider unusual. Also, when the calcifications start to appear on very young patients, and then also if that calcification has some sort of abnormal pattern. When we have these abnormal calcifications, they can be sometimes associated with a patient having blood vessel problems. There can be some underlying disease. There can be infection. Also, there can be tumors associated with these calcifications. So again, when they're seeing calcium inside of the skull, it doesn't automatically mean that something's wrong, but they do pair it with things such as the patient's age, the pattern, and also the location. The next skull pattern is related to the paranasal sinuses. Typically on an x-ray, because our sinuses are air-filled spaces around the nose and face, they're going to appear really dark, the darkest shade of black that we can see on the x-ray. Now, if the sinuses start filling up with something, and that something could be a mass, it could be blood, mucus, or fluid, on an x-ray it will start to look cloudy, or it can start to look white. So that means that there's something there in the space besides air. Now, sometimes the most common cause of this filling effect or this white cloudy appearance is the patient might have something called sinusitis, and with that we're looking for, on the x-ray, we're looking for an air fluid level where we can actually see a line between the air and the fluid. That is a classic sign for the radiologist or doctor to say that the patient might have acute sinusitis. Now, trauma can also cause blood to collect in the sinus, and also things such as cysts and tumors, which are less common, they can cause the sinuses to look opaque on the radiographic image. So the main thing to remember when we're looking at the sinuses, a normal sinus looks very dark, and again, that's because it's filled with air. So if we start seeing the sinus looking white, bright, or cloudy, the doctor has to determine what is actually filling the space. The next skull pattern involves wormian bones, and wormian bones, as you're learning your skull imaging, or as you learn with skull imaging, are basically small extra pieces of bone that form in the sutures or also in the joints of the patient's skull. Now, wormian bones are normal when we're talking about very young infants, so it doesn't necessarily mean there's something wrong if we're seeing it in a young infant. However, when we're seeing wormian bones in older children and also adults, it can be associated with different conditions that can affect normal bone development. Some of those conditions you learned about earlier, that's the osteogenesis imperfecta, also rickets and cleidocranial dysplasia, all of those can affect the wormian bones. So again, they're not necessarily alarming when we see it on younger infants, but when we see it later in life, we might, or the radiologist might want to take a second look or get, additional imaging to see if there's something underlying in terms of a bone disorder. The next skull pattern is solitary osteolytic defect. So when we're looking at these on an x-ray, we're basically seeing one area of the skull where there's some sort of bone loss that's been lost or destroyed. On the x-ray, it's going to look like a dark spot or a hole in the skull. And some of these findings can be harmless. So things like that donut lesion where we see the dark center surrounded by a white rim. While some of them can be harmless, there's some that can be of interest to the doctor to do some further testing. So some of these can be caused by things like surgery or trauma. Some can be caused by a cyst. Some can be caused by infection. The person might have a tumor, or there might be some sort of metastatic cancer going on. So when we talk about solitary, we're talking about there's only one area. And when we're talking about osteolytic, that means there's some sort of destruction of that bone happening in that area. So we looked at solitary osteolytic defects. So now we're looking at multiple osteolytic defects. So instead of just seeing one area of bone where it's lost, we're now seeing multiple dark areas or multiple holes throughout the patient's skull. So when they're looking at this imaging, the patient's age and the appearance of those areas is going to help the doctor or radiologist determine what the cause is. So one of the most important patterns to recognize is for this particular condition is multiple myeloma. When we see multiple myeloma on imaging, typically it's going to produce punched out lesions that look like someone just punched a lot of holes throughout the patient's skull. Metastatic cancer can also produce multiple areas of bone destruction, but they're often different sizes and less uniform. Another condition is hyperparathyroidism. It can produce some of these same widespread salt and pepper appearances. So again, the main thing with this one is we're seeing multiple lesions versus on the last defect, osteolytic defect, we were talking about a single or solitary one. All right, so again with this, these lesions, we're typically going to be looking at age. This typically is going to be seen in our older patients. And with this also, the doctor might start to lean toward multiple myeloma. The last skull pattern is related to radiodense lesions of the mandible. So we're basically, when we're looking at it on an x-ray, the area appears wider and more dense than the surrounding bone on the x-ray. So again, with this lesion, it is typical that they may change in appearance over time. They may start out looking dark. That just tells us that the bone is being lost. And then later on, as we continue with imaging, they might become white as new bone is actually starting to develop or calcify. A good example of these are cementoma, where we can start as a dark area and gradually become a dense mass, a white mass. And then odontoma can also appear very dense, and it also can contain some tooth-like structures as well. Infection and also other bone diseases can cause some of these changes as well. So again, with these types of lesions, we might see a white or dense area in the mandible. So again, with this, we're going to also be looking at the location. We're going to be looking at the appearance and also how the appearance changes over time. And that'll typically help the radiologist or the doctor determine what the overall cause is. All right, now we're wrapping up the skull patterns, and this is just our summary of what we discussed. So again, with those skull findings, typically the radiologist or the doctor is not going to base it on the skull appearance alone. Some of the things that they need to take into account when they're looking at a pattern is sometimes they may need to do measurements. They're also looking about the location of the appearance, and then also the patient's age as well can be telling on what it is. Something that's normal in a baby, such as those wormian bones that we talked about earlier, can be very abnormal when we're talking about an older child or an adult. In the jaw, when they're looking at these, or when you're even looking at these, even though you're not making the diagnosis, we're looking at where that lesion is. Is it connected to a tooth? Because that typically is going to point more toward it being a dental cause. If it's not related to the tooth, we're typically going to consider some type of underlying disease that's affecting the rest of the patient's body. So another thing to remember is that, the x-rays may identify that something looks abnormal, but that patient may need advanced imaging modalities like CT or MRI to actually help assist in diagnosing what the underlying disease or cause or pattern is. So again, even though we're trying to learn how to recognize a pattern, we have to take into account the patient's age, the location of the pattern, and also measurements to kind of narrow down what possible diagnosis the patient will receive. Here's our quick review of some of the patterns that we talked about with regards to the skull. So again, we're not trying to memorize any of these diseases, and we're not even trying to diagnose any of the diseases. We're just trying to focus on trying to match what we might see in an x-ray with the pattern in terms of what we learn. So in terms of if we see that the odontoid is sitting too high above what we call that McGregor line, some of the things that we're going to think about is that basilar invagination. If we're seeing a dark area in the jaw surrounding the crown of a tooth that hasn't erupted yet, it might suggest that there is some type of cyst there. If the entire skull looks less dense or somewhat washed out on our imaging, we might think of demineralization. If we're seeing an enlarged sella turcica and we have that double floor sign appearance, it could tell us that there might be some type of pituitary mass or some sort of erosion going on. And if the skull looks unusually thick or white on imaging, that might point us to increased calvario radiodensity. So again, these are just some signs or some clues. We're not trying to diagnose, but of course, in our job, we're going to see some of these things. Now, even though skull imaging might be far and few in between, just because a lot of these patients go to CT now, there may be opportunities or chances that we see these things, and this just gives us an idea or a clue on what normal looks like versus abnormal looks like. Here's our final look at some of the patterns that we talked about with the skull imaging. The first one is calcifications inside of the skull. So remember, calcifications can be normal, especially when we expect them based on the patient's age, and also when they appear in a location that we typically expect them to be in. But when they're unusual in terms of the patient's age, unusual in terms of the location or even the appearance, that can be a warning sign for us or for the radiologist and the doctor as well. If we're seeing an air fluid level inside of the sinuses, again, remember the sinuses are typically supposed to be filled with air. And if we're seeing that cloudy white appearance versus a dark appearance, because air appears dark, like you see the air in your lungs, that usually points to the fact that that patient might have some sort of sinusitis going on, some sort of sinus infection. If we're seeing multiple wormian bones, again, based on the patient's age, because in an infant, it might be completely normal, but in an older patient, that might suggest that they might have some sort of bone disorder. If we're seeing multiple punched out areas in the skull, especially if we're talking about an older adult, we might look at multiple myeloma as the cause. Also, if we see a dense or white lesion in the mandible, that might also point to a condition called cementoma. So again, these are just patterns that we just learned about. We're not diagnosing the patient, but if we can identify that something looks abnormal, it might get the patient to their follow-on treatment faster, especially if we can bring it to the radiologist's attention prior to allowing the patient to leave. So again, looking at the patterns, not necessarily trying to memorize or recognize the patterns, but just have an idea of what these patterns look like, coupled with the clinical history and also the patient's age and some of the locations of these things can help us just be better at our job. Here's our final takeaway from our skull chapter, our skull patterns chapter. So again, our goal is not to memorize all of these diseases, and our goal is definitely not to diagnose as a technologist, but we do want to have an idea of what normal looks like and also what abnormal can look like. So instead, when we're looking at some of our images, especially with the skull, since we're focused on that, and we're looking for things such as, is the bone darker or whiter than it normally would be? Is there one lesion or are there multiple lesions? Is the pattern involving the jaw? Does it involve the sella turcica? Does it involve the sinuses, or does it involve sutures? In terms of measurements, although we're not doing any of these measurements, those measurements can help us decide whether something is normal or abnormal. And last but not least, although we're not making the diagnosis, some of the things that are considered are the patient's age. They consider the symptoms, and again, they consider these as well as the locations. They consider these because some of the findings, like wormian bones and also some of the calcifications that we might see, they might be completely normal for one patient, but abnormal for another patient based on their age and also based on the symptoms. So again, somewhat trying to identify the pattern first, although we're not memorizing any of these things, looking at where the location is of the pattern. Typically, we're not making measurements, but the doctor radiologist will make measurements, thinking about or looking at their age and also some of the symptoms or their clinical history to kind of narrow down what the cause is.